Yes, now we can hear you. Please go ahead.
Yeah. Good evening, all. So, can you hear me now? Good evening, everyone, and thanks for all this time. So, I just before I go to the case, I'll just introduce my team. So, I'm Dr. Refai Showkathali. I'm at Apollo Chennai, and we have Dr. Radhapriya. She's my associate. Dr. Andrew is our technician, and Geeta Priya is our nurse. Dr. Karthik is our anesthetic team, and we have plenty of team from Abbott for OCT, and we also have a team from Transilumina for helping us with IVL. So the gentleman today is a 73-year gentleman, known to have diabetes for more than 20 years, with high blood pressure for more than 15 years. He's been kind of uncontrolled with diabetes for a few years, and has been having recent onset effort dyspnea for the last few months, and ended up seeing a cardiologist in his local town, which showed an echocardiogram, which showed a calcified aortic valve with a mild aortic stenosis and a mild aortic regurgitation, but a well-preserved LV function. And they mentioned some regional wall motion in the anterior territory, but the LV function is well preserved. So they put him on a treadmill test. The treadmill test was positive for inducible ischemia, and therefore he underwent a coronary angiogram on the 20th of this month in the hospital where he has been treated a few days ago. Shall we go to the next slide, please? So you can see this is the first shot on your left hand is the caudal view.
See our slides.
Can't see the slides. Sorry about it. Just hold on, we'll get it now. Can you see now?
Oh yeah.
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 You can see now? Fantastic. Okay, shall we just play this angiogram? So this is his angiogram. As you can see, he's got the first on your left-hand side is a caudal view. It's showing a good size left main stem. And you can see the disease starting at the distal part of the left main, going into the ostium of the LAD and also ostium of the circumflex. So it's a Medina 011 bifurcation lesion of the left main. But you can see also the amount of calcium before the contrast goes in the part of left main and the LAD. And on the cranial view, you can see the LAD, the mid segment of LAD is around 70 to 80% stenosis, quite a reasonable long segment of stenosis. And starting point of the diagonal, the ostium of the diagonal is diseased, but that diagonal appears to be not that big when it tapers down. Also on the caudal view, the next picture, please. There's a big sized obtuse marginal branch coming, and there is the second obtuse marginal has got a very severe lesion at the proximal and the osteoproximal segment, around 80%, and it's a big size, around 2.5 millimeter vessel of the obtuse marginal artery. And you can see the extension of the circumflex lesion going up to the second obtuse marginal, around 10-15 millimeter down there. And on the spider view, the leliocaudal view, you can nicely see the bifurcation, the angle of around 70 degrees, more than 70-degree angle of left main LAD to the side branch, which is the circumflex. Next view, please. So on the right coronary artery, they tried to inject the right coronary artery. They could not see anything. They just did a non-selective injection of their RCA, which looks like a very non-dominant RCA with the small branches coming there, multiple branches, but nothing significant noted on that right coronary artery at all. Next one. So I can see this slide showing the calcification of the LAD, the left main, and the bifurcation, the ostium of the circumflex as well. Next one. So we did a syntax score on him, including the bifurcation disease and also the obtuse marginal artery and also the mid LAD, and we got a syntax score of 26. And when we did the syntax score 2, including his age, creatinine clearance, he's got a renal function is normal, and his LV function is also normal. So we had a syntax 2 of PCI, 4-year mortality is around 8.6, and same with the CABG around 8.6%. So we thought there is no difference between CABG or PCI. Nevertheless, we discussed the option to the patient and his family. They're not very keen for CABG, and therefore we decided to do angioplasty. So I'll stop here and open up for the discussions how the plan is. We started the case now. So we tried to do with the right radial access with the 7 French sheath, but unfortunately he has got calcification in the radial artery. So when I could not get the 7 French slender sheath through the right radial artery, so I decided to go on the right femoral artery with the 7 French sheath. On the left-hand side, considering it's a left dominant system and his LV is also completely normal, but nevertheless, because of the calcification, I decided that he may need a support to start with So preemptively, I put an intra-aortic balloon pump on the left femoral axis, and his blood pressure is quite stable around 130 systolic, going up with the IABP of around 165. Yeah.
Dr.
So
Refai,
what we've done is we
before,
have wired
before
all these three branches. The main idea was to wire the LAD, which I've done, the wire the circumflex, and wire the obtuse marginal. I didn't want to do anything with the diagonal, considering his age and everything. So all three branches has been wired, and I just did that 2.5 balloon dilatation of the LAD, the left main, and also the circumflex and the obtuse marginal. And then we decided to run an OCT run. So, are you happy with the OCT? Shall we show the OCT? Yeah. So we just took the OCT run. So when we went on live, so we're going to show the OCT. So this is the OCT run from LAD to the left main. I'm trying to go and do another run from circumflex to left main as well. So, yeah. While we are waiting here, I'm okay for any open discussions and any strategic plans from the team, or would you have done anything differently? Would you have thought about anything differently at this stage?
yes, Dr. Masuda, can we have your comments, especially as far as your plan for this case would be concerned?
It's a tough question. It's a tough case.
So, what is the you're getting in the left main?
Do you use any ablation device?
Beg your
Sorry,
pardon?
I didn't know.
How about the rotablator?
Okay, Dr. Refai has just done the OCT after doing a balloon dilatation, and he has not done a rotablator. He has done a OCT, and probably he's planning for a IVL. So, in such a situation, if you were the operator, how would you plan the case? Dr. Masuda, please.
Hi. Sorry. Could you say that again?
Dr. Refai has done balloon dilatation of the LAD and has done a OCT, and after that he is going to use an IVL. Now, in such a situation, if you have a left main bifurcation, calcified lesion going deep into the LAD and the left circumflex, how would you plan your case if you were the operator?
If I were operator, I plan one stent strategy, and I stent RMT to LAD, and about rest circumflex. Regarding the left circumflex osteo, I tried after the ablation drug-coated balloon.
Would you use a rotablator before using a balloon?
Yes, yes.
You're okay there.
Why would we use a rotablator and why not IVL? Sure.
That's enough.
Sorry, I can't see proximal region already.
Okay.
So,
yeah, ready? I'm ready.
Firstly, I see angiogram. I think ablation. I need any ablation device. But after the ablation, after the POBA, the OCI shows a crack. So I think mid region we need to ablation device, but proximal region. Sorry, I can't find the proximal region in OCT image.
Okay.
So
can you find or can you show proximal region?
Okay.
Just get ready.
Now,
Sister.
may I have some comment about approaching this case comment from Dr. Kaparthi, please.
Calcium, right?
Here. If calcium thickness is over 500 micrometer,
Yes.
I need I think I need a rotator because maybe
at 5 o'clock.
Cutting button is not effective in this region because the calcium thickness is so
yeah, there is calcium. Yeah.
Yes. Yes.
360-degree calcium on the circ as well. So we'll go for what do you
yes.
the proximal circumflex. What is the size? Luminal size. We used to use IVL balloon we are planning for. I'm going
Dr.
for
Rafael, is that the circumflex you are showing, the OCT?
Correct. So this is what this is the second OCT run. So what I did is I ballooned the obtuse marginal ostium with the 2.5. So you can see some good flow there. And then I used a balloon to the circumflex just below the obtuse marginal. And then we did a OCT run. As you can see, this is the pullback from circumflex, mid-circumflex into the left main. As you come along, you can see the lot of calcium around 3-4 o'clock position. And now it's coming back again. It's all around with a significant stenosis of the circumflex. And at this level, we can stop here. So you can see the calcium from around 3 o'clock to 9 o'clock. This is well established calcium on the inferior aspect. And coming back here, we're having more and more calcium coming. And on this is the POC. The ostium of the circumflex as such doesn't have that much calcium. But then they'll come back proximally. And this is the left main. Again, on the left main, there's not much of calcium. But there is on the it's a good size left main, and the mid shaft of the left main appears nicely bigger size. But having looked at the angiogram, my plan is to do a DK crush technique with proper debulking with the intravascular lithotripsy to both the circumflex and to the LAD. And then we're planning to do a DK crush from circumflex as a side branch and the LAD as a main branch. The obtuse marginal, I'm not planning to do anything with the obtuse marginal apart from ballooning, considering his age. But at the end, I may consider doing a DCB to the obtuse marginal origin with a 2.5 millimeter magic touch or any DCB available. So this is the segment. Where are we now? This is circumflex. So this is the landing zone of the circumflex. You can see a 360-degree arc of calcium. And what is the size we are getting of the vessel size? So any thoughts on what sizes of IVL we can consider here?
Yes, Dr. Kapan, dilate.
Come to the LAD run. LED run. I just want to see the size of it.
We can't hear you.
2.5. Yeah? Shall we go for the 2.5? No, LED. Just show the LED.
Yeah. Okay, we can't hear Dr. Kaparthi. There's some issue about his audio. So your preparation of the lesion, you are going to do with the IVL rather than a rotablator. And your size there is about 3.5 distally circumflex diameter. So which balloon are you choosing for an IVL?
Shall we go for 3 and just do for both? 4 atmospheres. 3 is what I initially thought.
Hello, can you able to hear, sir, Dr. Uday?
Yes, now we can hear you.
Yeah.
So
actually, the issue is definitely unequivocally lesion modification device, that is IVL, they are using. For circumflex ostium, 2.5 mm IVL balloon is useful. And for LAD ostium, definitely you have to use a 3 mm IVL balloon for lesion modification because of the extent of the calcium of more than 180 degrees, as well as the sheet of calcium, deeper calcium is more than 5 mm. Definitely the IVL balloons are useful for both the ostial circumflex and the LAD before DK crush, so that the expansion of the stent will be adequate.
Yes, another issue is that the depth of calcium is more than 500 microns. It's approximately 500 microns. So I doubt if we do a rotablator, we'll be able to debulk that calcium as much as it can be done effectively by IVL. Even a cutting balloon would not be effective to reduce the calcium.
Yes.
So, Dr. Refai, What size of balloon have you chosen?
We've decided to go for a 3 millimeter IVL balloon. So what I'm planning to do is the same IVL balloon to use for the LAD. So if you look at the, I don't know whether you can see the screen now, that is the 2.5. I'm trying to expand. At that level, it's not fully expanded to the balloon. So you can see there is a concentric of calcium sitting there. And considering the left main and the ostium of the LAD is a good size and the circumflex ostium is also a good size, I've decided I'll go for a 3 IVL balloon to do both LAD and the circumflex of the same balloon, rather than taking 2.5 and 3, because obviously cost is also an issue we need to take into account. So a 3 at for the proximal LAD, and then the ostium of the LAD, and then the 3 millimeter IVL balloon to the circumflex ostium, the proximal circumflex. That's the plan.
See, you have to do a IVL for the mid LAD up to the ostium of the LAD with this particular balloon, and then the circumflex. Do you think you will have enough cycles there to take care of both the LAD and circumflex with one balloon?
Well, I think that's a very difficult question to answer. We'll do a LAD with 2 pulses of the proximal LAD, and then pull back and do another 2 pulses, 2 cycles, and then see what we can achieve by running a OCT again to see if that cracks through. And then I would consider the circumflex, because for me, LAD is more important. So I'm not going to decide to put the IVL balloon to the circumflex until I get a good results in the LAD first.
Okay, and taking a second balloon for the different balloon for the circumflex would add to the cost.
Correct. So what I'm saying is I would try and get the lesion preparation of the LAD and the proximal LAD as much as possible. And then I will do a OCT run to see whether we have got the calcium cracked on. And I'll try and use a 3 millimeter balloon and make sure that the balloon is fully expanded in the LAD. And then I will put the same IVL 3 millimeter balloon into the circumflex and do that. So we're going to take a slow steps rather than just directly going for the next balloon. So just to avoid that. But in case if the LAD is not expanded with a 2 and 2, 40 pulses, then I may need to go back with the IVL into the LAD and do more pulses.
I agree.
I'll also see what's the expansion in the LAD as well.
Yes.
Hello. Suppose if you do oversized IVL balloon, any anticipatory problems?
No, considering the size of the LAD and the left main, it's unlikely we will have. I mean, from the data from the DISTREP 3 CAD trial, there's very little in terms of perforations with the IVL. I mean, that's one of the things we choose IVL is much more safer than rotablation. I mean, obviously, we've been using rotablation for many years. But one of the problems with these kind of patients where we have a left dominant system, where you are dependent on completely on the left dominant system, there may be issues with slow flow when you do rotablation, which can put us in trouble. And that is the reason why I chose IVL here. And also, as you said, is the concentric calcium all around the 360-degree R. We may need a bigger rotor bus. As we increase your bus size, your chances of slow flow increases, and the patient is particularly dependent on the left system. He may have issues during the procedure time. So that's why I chose IVL, much more safer in terms of complication rate considering rotablation.
And looking at the depth of the calcium on your OCT, I feel even if you have to use a 175 burr, it will not give rise to as good an effect as compared to the IVL.
Absolutely, I totally agree. I have used 2 millimeter rotaburr as well at times, but it's very difficult to get 2 millimeter burr in India. But we had special orders and kept it in our cath lab just because there are 2-3 cases before IVL came. We have difficulty with the 1.75 and we could not get a good result with the stenting. So we have 2 millimeter burr in those kind of cases. But now we have IVL available, so we are trying to use the newest technology, much more safer than rotablation.
Yes.
So this is the IVL catheter.
Dr. Masuda,
Hi.
what are the largest size of burrs, rotablator burr, available to you at your institute?
On the lady, right?
If I use rotablator bar to circumflex artery, I choose 1.5 maybe 1.5. First, I choose 1.5, and after the ablation, if I need a more bigger size bar, I use 1.75 or if or 2 mm bar. In Japan, we can use only two rotablators in one
Yeah.
procedure.
Okay.
Point well taken. Dr. Kaparthi, want to
Yeah.
add?
Nothing actually, because as calcium is deeper, definitely IV is useful. Only my potential thing is because complex is dominant. Suppose if the oversized balloon produces a dissection and suddenly emergency situation, he has to stent the LMCA circumflex rather than a DK crush. It may to be provisional stenting if acute dissection with acute vessel closure occur. That may be a potential anticipated problem which you should be ready.
Would you, looking at the angle of the left main and the circumflex LED, it is less than 70 degrees. DK crush is a very good choice
Very
for
good
this
choice.
type of an angle. Would you consider a culotte or a mini culotte in this particular patient? Dr. Masuda?
Sorry, could you say that again? Sorry.
Looking at the angle of the LAD and the circumflex in the ileocaudal view, the angle is less than 70 degrees. In such a situation, while stenting, would you consider culotte besides having a thought of DK crush? A culotte?
Maybe I choose a curiosity. In because the bifurcation angle is over 17 degree.
Yeah.
So in my impression, I think that DK crush is cross testing is better in this station.
Okay. Dr. Kaparthi?
Yes, sir. It is one of the important alternative. DK crush is associated with a long-term results. That's why we prefer DK crush compared to the collote.
I
In
agree
this
with
given.
you. I think it's a reasonable choice, reasonable selection in this particular case.
Yeah.
I think he has done the mid LED and is most probably pulling back.
LED.
Okay.
Sorry, can I have one question?
Yes.
I don't have experience of use of shockwave.
Yes.
So how about slow flow phenomena? Can I
Slow
use
flow.
slow flow? Yeah. Is it
Yeah.
often occur?
Yes. Now, compared to rotablator in such a heavily calcified vessel, there is a concern about slow flow after a rotablator. But since he is going to use an IVL here, I feel the chances of patient developing slow flow would be less. We have to keep it in mind, but still the chances would be less. You can see that angiography which he has done now. It shows. Can play the even with the balloon in the proximal LAD. In spite of that, you can see there is hardly any. There is rather no slow flow at all.
Yes, yes.
So how is the crossability of
Yes.
shockwave balloon?
Crossability of the burr. Crossability of the balloon for IVL is a problem, especially if there is too much of angulation especially because there is so much amount of calcium over there. That is why prior to doing the IVL, the shock therapy, prior to taking the balloon in, he has done a POBA for the LAD by, I forgot, I think he has used the 2.5 balloon. And after doing the ballooning, he is doing the shockwave therapy. That's why the possibility is not an issue. If you were to use the balloon directly without dilating prior to using the shockwave balloon, then the crossability would definitely be a problem. What do you think?
Left LAD to left main, and then decide whether we'll go to surgery.
Another important clue, Dr. Uday and Dr. Mitsuda, there is only a deep calcium and mild superficial calcium rather than calcific nodules in the OCT. The OCT calcific nodules are there. Definitely, passage of IVL balloons becomes a little bit difficult because of its bulkier nature.
Yes, I agree with you. This is more of a concentric, almost a concentric calcification or 180 degrees calcification minimum rather than nodules. Whenever there are nodules, the passage of the balloon is difficult. I think he has completed the proximal LAD also. So let us wait for his angiography that will tell us how good the result is, and an OCT run after that, along with that.
Okay, let me just do one. So essentially, as we rightly said, we did 20 pulses on the just on the proximal LAD and the 20 pulses in the ostial LAD. And angiographically, we thought it was opened up with the balloon, but it looks not in the proximal part. There's still a lot of calcium here. So I thought I'll just run an OCT and see what happens, and then we will decide whether we need to extra pulses in the ostial LAD. But I think the proximal LAD, I think we don't need any more pulses because it looks okay.
The mid LED is very well done.
That's right, yeah. So I'm just going to go back and with the OCT and see what it looks on the proximal and the osteoproximal LAD.
Sure. Now, Dr. Masuda and Dr. Kaparthi, we are using an OCT over here, which is a good tool for imaging, especially when there is so much of calcium.
You don't need to.
Do you consider, instead of OCT and IVUS, what would be a choice, Dr. Masuda?
Sorry, your voice is so noisy. I couldn't hear.
Okay. Compared to OCT, would you choose an IVUS for imaging in this patient? Would you use an IVUS rather than OCT in this particular patient?
Would you use a particular, sorry?
Intravascular ultrasound.
IVUS or OCT?
Yes.
I prefer I prefer OCT to IVUS because when I use developing device, OCT can visualize the calcification and the lesion lengths. So in Japan, we often use OCT or OFDI. We use a developing device.
Yes. And I think this OCT shows a very good result in the LAD.
Yes. Fracture of the calcium. Yeah.
That's right. You can see nicely the cuts with the coming into all the way into the media. So I think I'm happy with the LAD. I'm just going to think of putting a IVL onto the circ ostium and the proximal most part of the circumflex and do the same 40 pulses.
Yeah.
So I think you have consumed about 40 pulses all put together.
So we have done 40. I got another 40 to go on this catheter. So I thought I'll use that another 40 to go.
Yes, Dr. Masuda, you are raising concern about slow flow or no reflow after IVL. You can see on the OCT as well as on the angiography that IVL has not given rise to any disturbance of the flow. That is another advantage of IVL.
Okay.
I think the main point is about the selective sonic waves cutting the calcium without disturbing the normal vessel wall. I think that's the beauty of this technology, that in the normal vessel wall, it doesn't do anything, very limited effect on the normal vessel wall, but just purely cutting the calcium through the sonic waves. So sonic waves doesn't have any major effect on the normal endothelium, normal intima and media. Just come to spider, Andrew, please. We'll just.
Now, Dr. Refai, as
Yes,
you are
sir.
passing the balloon into the circumflex, we see, and that was the concern raised by the other panelists also, we see that you took it inside the LAD with lot of ease. Now, looking at the angle of the circumflex, just let us know, is it equally easy to go across this
No,
circumflex?
I can feel the resistance. I'm trying to just deep throat the guiding catheter, as you can see just now.
Yes.
But it's not coaxial. Let me just test.
Yes.
Sometimes you may need guide gel also.
That's correct. Yeah. So the guide is not coaxial. So I'm trying to see whether I can get the text.
So that answers one of the queries raised by Dr. Masuda, that whenever there is severe calcification and too much of angulation, it may be difficult to take the balloon across, as we can see in the while in the LED, it was very easy to take the balloon across.
Let's put the guideliner.
The
The second thing is guideliner, which is an appropriate choice in the present situation. Dr. Kaparthi, would you like to add some comments to this?
Yeah, definitely. Actually, whenever a type of superficial calcium with some obstruction, tight lesion was there, definitely it is difficult to pass a bulkier balloons like IVL or angiosculpt or flexstomes. Definitely needs coaxial alignment along with guide extension catheters so that you can place the device across the calcium blocks.
Yes.
Yeah.
Point well taken. So that is why they are taking a guidezilla to take the balloon across.
Yes.
It may be difficult even with a guidezilla, especially when you are referring to an IVL balloon which is already inflated in the LAD. Probably a new balloon would be easier to go across, but then that would add significantly to the finances of the patient.
Yeah, it loses its profile once it was inflated.
Yes.
Yeah, so the other option would have been I could have used for the circumflex and come back to a LAD, because as you also know, the circumflex angulation is making difficult for me to pass the IVL. But the chance is, because I want to make sure that I get a good result in LAD, because for me, for this 75-year-old gentleman, I want his LAD to be perfect rather than circumflex. So that's why I chose to do circ first.
But Dr. Refai,
LAD first.
Patient, the circumflex is also equally important because the right coronary artery is a non-dominant coronary artery.
Yeah.
So both the arteries are important, and probably if you have done the circumflex first, gone to the LAD next, then doing the mid LAD also would have been difficult. Proximal would not be a problem.
Right. Difficult to do this because of the 3 wires and because I have 3 wires here. Or just 1 second, I'll try and see the OM wire. I can just pull the OM. See whether that helps the pushing my guidezilla to that.
Yes.
Because
this
my guidezilla is not running smoothly with the 3 wires in position. So I've just pulled the OM wire out to see whether I can push the guidezilla very gently in. Fix the wires.
I suppose you are using a 7 French system.
It is, yeah, it is a 7 French system, but yeah, it's going.
I think the guidezilla should go through now because the OM wire probably must have got entangled on the way.
I think the problem is with this sketch. Yeah, I think I'm finding difficult to pass through the guidezilla through that. Yeah.
Dr. Kaparthi, in
Yeah.
such a situation where he is having difficulty in taking the guidezilla through,
Yeah.
would you like to use a balloon to support the guidezilla?
But
Actually,
the guidezilla problem I'm having is in the here rather than, I think this the problem is the catch.
you can use
With
a
the
distal
white-
anchor. Distal anchor you can use.
Take the one, yeah.
Yes.
Give me the
You
another.
can pass the balloon distally, you can anchor it. Then you can advance the guide.
Usually should run.
But I
with
think
wire.
his problem is with the Y connector
Catch.
valve.
Correct. So
Okay.
the Y
Okay,
connector
okay.
I have is not getting through. It's not even reaching. So we're going to change the Y connector because we have 2-3 different companies coming, and suddenly we had this one on, which is because we normally should not have a problem with the 7 French guiding and the guidezilla to run through with the 2 wires. We normally routinely do that, but I think this problem with this Y connector, as you rightly said.
Yeah.
So we're going to change the Y connector because now we got just 2 wires in. Get the introduce the needle. So what we can do is we just need to remove it and feed the introducer needle and just feed it.
I will let Dr. Refai take care of the issue. In the meantime, Dr. Kaparthi and Masuda,
Yeah.
do you think there are different sizes of valves of the Y connector? Does
Yes.
it make a major difference?
Yeah, yeah.
Different?
Actually, in the Y connectors, usually in the Japanese, there is a push-pull Y connector cutter. Okay, that Y connector okay is very easy, so that it won't feel resistance, especially when you use these guidezilla, anchor balloons, and all these. It is very easy to use, very user-friendly.
Okay.
That is okay Y connector actually.
Yeah, we usually use E-turn or OK.
Yeah,
Yeah, it's so friendly.
yes, user-friendly. That okay connector is.
No, it will guide check.
Because as far as the size is concerned, the internal diameter is concerned, there are not major differences with them.
I'll just put one and see whether it's.
Probably
I think
in
we
this
should put the
particular
other one.
case, the valve must be having a problem after multiple passing of the balloon, OCT, and all that.
Suppose having had the difficulties here, is there any alternative for him? Changing of the guide from XB to the amplage so that it has a good coaxial length to the circumflex?
No, it's not the problem of the angle. The problem is the guidezilla is not pushing from the catch area. We not even reached the iota. So the problem is not with that. It's the problem is with the Y connector. Can we introduce it?
Okay.
Yeah. Actually, after performing a balloon dilatation and after performing giving shock therapy, in such a situation where there is quite a big angle between the left vein and the circumflex, I would be hesitant to change the catheter unless and until it is mandatory for some other reason. Because changing the catheter and then taking new guide wires across would be a very tedious job. Dr. Masuda?
Oh, don't pull anything. Guidezilla.
Sorry. Could you say it again? Please.
How smoothly it runs.
You can exchange on the same wires with a guide wire extension. The because already 2 wires are there, you can exchange XB to the amplage. Actually.
Also, it will go. Yeah. Okay, so we checked it outside before I remove it, and it is working with the other Y connector. So I'm going to connect it, disconnect it, and connect this. So we need to. What we need is you need to hold this guiding. So I need to feed that 2 wires through that because we will lose some blood out.
Will you need to put 2 needles inside the Y connector so that the
We have
wires...
only one camera. That's the way we need to go in white needle. Introduce a needle system. Introduce a needle. Needle in. Push the needle in, sister. Push the needle in. Keep it pushed. Yeah, that's it. Keep it pushed inside.
Okay.
So I just need to feed that through, and then we will exchange the needles. Wait.
Yes.
Remove the
That
needle
is a
now.
better
And
technique
put the other needle in.
so that the valve doesn't get damaged.
Yeah. We'll just give you the other one. And then yeah, just keep it pushing. So we'll feed the other one, and then we are done. One second. Keep it like that. Keep it like that. Push. Keep it push. Yeah. So I've got 2 wires fed through the thing.
Very good. Very good. Very good.
Okay. So you just connect the thing. Yeah, you leave that to me. Thank you. Keep flushing. Keep open. Keep this open so we know what we are doing. Okay. Fine. Okay. Now we will set the guidezilla, please.
Yes.
No, we are okay. We are okay. Just aspirate.
In the meantime, Dr. Refai, if somebody
sir.
else in your cath lab can examine that Y connector and see if there was any significant damage to the valve.
Well, definitely we need to look into that, the valve system. Why it was difficult to pass a guidezilla through that. Right.
Yes.
Let's.
Now, when you are taking this guide,
So what my plan is, I'll get the guidezilla all up to the ostium of the left main. If I'm finding too difficult to get the guidezilla further, I'll use a balloon technique where I put the balloon at the tip of the guidezilla and then push the guidezilla into the circumflex. So 2.5 balloon ready. Let's fix the wire now. Yeah, so you can see the difference. So this is also can.
yes.
Oops, something is behind. I'm finding difficulty. Yeah, just keep the wire in.
Where?
Keep the wires. I'm trying to. Andrew, we may need to. 1 second. Yeah, but screening. No, both wires have come out actually. Okay, just to remove the guidezilla. So you can see the wires have come out. So I just need to rewire it because of the techniques we have done. Okay, why?
Now, since you are having problem with the second guidezilla also, is there a kink in the guiding catheter?
Well, no, it's not. It's looked very straight for me here. It's only in this particular part of the distalmost part here is the problem. Get a talk around the wire. Get a 6 French guidezilla. Yeah, because it's smaller. Okay, just talk around this wire. Andrew, show me the. So that's my run through. Test.
Okay, we'll allow Dr. Refai to work and sort out the problem. In the meantime, Dr. Masuda, in patients where there is a lot of calcium and we require a good support of the wire, which wire do you use routinely in this type of patients?
What kind of wire?
Yes.
In this patient, I usually in this patient, maybe I use a support wire, the Sion extra support, for example, because we use we consider durability.
Yes, because in here we require there is some amount of angulation, especially for the left circumflex. That's why we require a good support from the body of the wire also, and would need an extra support wire to take care of the passage of the balloons across and the material, other devices across. Here we are having some problem with the guideliner also. What about coated wires?
Okay, so the LED is wired now. So let's put on this one. 1 second. So let's do the needle. Andrew, just give me a 6 French.
Doctor,
Put that on the
can you hear us?
Sorry, you're asking me?
No, Dr. Kapar. No, you work there. We will not disturb you.
Yeah.
Once you are comfortable, let us know.
Sure, sure, sure.
Dr. Kapati.
Sir, actually, I can tell one technique here. Usually, what I have seen, even though it is a 7 French, once two wires are there, there's a lot of friction is there in passing the guidezilla. So, better LED wire, you can remove it. And then one wire in the circumflex, you can smoothly park the guidezilla across the circumflex. If any difficulty is there, by means of inchworm technique, that is a balloon assisted advancement of the guidezilla. You can use this technique to pass the guidezilla across the circumflex so that you can pass the IVL balloon, the guidezilla beyond the lesion. That is the only technique available now. He can use it actually. As long as two wires are there, lot of friction and guidezilla will become damaged rather than second, third guidezilla also. I have encountered these difficulties actually, even 7 French guide also.
Yeah, but generally with a 7 French guide wire, this type of difficulty generally doesn't occur. It occurs with the 6 French guide catheter.
Yeah. Yeah, see, one of the things I now realize it wiring was not a big issue, LED. So I would use that technique, but now I can see I've downsized the guidezilla to a smaller size and 6 French guidezilla, and it's running smoothly.
Great.
So for IVL balloon, it doesn't really need to be a 7 French guidezilla. So I'm just going to use the 6 French, keep it in position, and try that.
Yeah. And if suppose any difficulty in the guidezilla passage, yeah,
I can use a balloon. Just give me a balloon.
Yeah.
2 or 2.5. 2.5 we have it no on the table.
Yeah.
So just give me the 2.5.
Guidezilla passage you can do. Yeah.
Yeah. So my guidezilla is on the circumflex wire, and it's just hitting on the carina. You can see. I'll just show you. It's actually looking down. Maybe I can try IVL without putting the balloon. The position is okay.
Yes. Now can use
Will you try the IVL and see whether it goes through?
Is it
Definitely.
possible to push the guidezilla some more inside?
Yeah, some more inside. I don't want to push through without a balloon assisted technique. So the choice is between using another balloon to get it down or IVL. I'll just give one try with IVL. If this IVL not use a balloon to push it down.
I think you would be comfortable with that.
Right. Fine. Definitely it will be. Yeah.
And show me the guidezilla, the other end of the guidezilla. Just make sure we are coaxial. They're here. When the balloon comes. Yeah. So I'm just trying to make sure that I go smoothly into this.
Yes, especially because we have already inflated the balloon in the LED couple of times.
Correct. So it's always better to check it through. Yeah, I got the balloon now.
Lovely.
Yeah, so let's check where we are. Okay, so the guy.
Dr. Refai,
yes, sir.
Can you show us a larger version of your active screen, please?
The angiography screen?
Yeah, angiography screen.
Okay, can we? I'm just telling the people here to just
single that one live
I'm
screen.
going to take a picture of that.
Yeah, live screen. Yeah, that's better. Visibility is better. Looks satisfactory in this position.
Very good.
We had a slight issue with the IVL balloon. During the process, the IVL balloon, we can see some blood back. There is some damage to the IVL.
Rupture of the balloon.
Yeah. So I'm going to take this balloon back. What I'm going to do is I'm going to use a cutting balloon. Or shall we just use a 3 mm normal balloon, NC balloon, and see how the expansion is, and then we will decide on that.
Dr. Refai, Dr. Masuda, now that we are going to use a balloon rather than IVL because the IVL balloon has ruptured, in such a situation, would you like to first go for a cutting balloon and then a NC balloon, or go directly with the NC balloon? Dr. Masuda, please.
It's
Do an NC3.
I
See how the expansion
use scoring balloon. I use a scoring balloon.
Okay.
Maybe cutting balloon cannot be delivered. The scoring balloon is relatively good crossability, so I try cutting scoring balloon.
I think this is a very practical point which you have made, that the scoring balloon would be easier to take rather than a cutting balloon in such a angulated case.
Yes,
Dr.
yes.
Kapati, please.
Yeah, definitely, sir. Flextome is more bulkier than the angiosculpt. Definitely, angiosculpt is very easy to take that angle rather than flextome.
Yes. Now the issue is taking that angle and going in. But as far as actual debulking is concerned, do you think
Flextome superior.
cutting balloon would be better?
Yes, flextome is superior to angiosculpt in debulking.
Okay. Point well taken. Dr. Masuda, you have preferred a scoring balloon over cutting balloon. But
I prefer cutting balloon.
So I'm going with the 3 balloon.
I prefer a cutting balloon to scoring balloon.
okay.
It depends on the torture stick.
Clean it up.
Okay. So he has gone with the NC balloon, ordinary balloon. And now we'll see his result.
And it has expanded. So I'm just going to see, I'm going to pull the guidezilla back and do the ostium of the circumflex test run. Okay, ready for a 2 ml shot. Yeah, go up again. So I've done one inflation on the proximal circ. I just pull back to see how it looks on the ostium of the circumflex, 8, 10, 12. Yeah, this is a 3 millimeter NC14. We can go up to. Yeah, you can see, I mean, I'm not sure how much is translating onto your screen, but we can see that it expanded, though the contrast inside is not enough, the dilution is slightly less. We cannot see clearly, but I can do one more picture. It's opening up down.
Yeah,
I'm
but
going to
if there's any waste there.
Yeah, it's going more. 2, 4, 6, 8, 10, 14. Yeah, I think that looks okay to me in terms of expansion. Down.
Yeah, it's actually expanded.
Nice for the wiring. I'm just trying to get the wiring. Yeah, and it. I'll just get the guidezilla. We need to do a little bit more in the mid circumflex, a little bit more. So I'm just trying to put the guidezilla back in.
Dr. Refai,
Yes, sir. Just test that.
yeah, how much atmospheres did you go up to?
We went up to 14 with a 3 millimeter NC balloon because we are planning to put a 3 stent to the circumflex anyway. Just go up to 14. Just want to make sure.
If I'm not mistaken, if I remember right, your distal circumflex was about 3.5 millimeter.
3.25, or what is the distal most part of the circumflex? Come down.
On the OCT?
3 point, yeah, it's a bigger then. So I may use a 3.5 balloon as well.
Yeah, then you can also afford to go for higher pressures over here.
Yeah, 16, 18, 20. Because the NC balloon, so expansion is it's even a 3.5, 3 balloon will expand only up to 3.2, even with the 20 meter atmosphere. So you can see the nice shape of the balloon, fully expanded there.
Yes.
Now. So, but to be on the safer side, I'll just pull back one more time and just to go up the ostium.
Yeah.
So guidezilla.
As you are doing that job, if I can speak to you, Dr. Refai.
Yes, sir.
there was a problem about taking material down the circumflex artery, and you already have a guidezilla over there. So, after this balloon dilatation, would you like to place the guidezilla before stenting into somewhere deeper into the circumflex?
Yeah, so now I have the guidezilla in, so I would not remove my guidezilla until I stent the circumflex, because I'm I don't want to remove the guidezilla. So now anyway we are going to do the plan is always going to be a DK crush, so the first stent is going to be in the circumflex anyway. So I'll use the guidezilla, get the stent in the circumflex, and then I will start from the LAD.
Yeah, but to carry the stent into the circumflex, where would you place the guidezilla?
Now I'm going to go with the guidezilla as much as possible. See, I'm trying to push on the balloon itself because to make it more easy for my stent to cross through. This is a little bit of angling of the wires here. Yeah, so you can see my guide. I'm just pushing both guidezilla and balloon together. Okay, I'll push the balloon back forward and guidezilla in. Okay, de-inflate, inflate to 2 atmospheres. So one of the techniques I use is inflate the balloon, deflate, and then deflate now.
Yes. So this is you are using inchworm technique.
Yes.
That's right, inch. So I'm just quite nicely in there. So here as well, I am. So my positioning of the stent is what I'm going to decide now.
Yes.
Yeah, so I think I probably start from that segment just below the guidezilla. So my balloon is, because there's no much lesion below that guidezilla segment, so I'll keep the guidezilla in position there and then try and decide the length of the stent. So this balloon, what is the length we have from the circumflex? If you can, what is the length of the balloon?
By the time he is working there, Dr. Kaparthi, in this technique, I always tell my fellows that you have to be very careful when you are pushing this guidezilla down, especially because you have already dilated with the NC balloon at 14-16 atmosphere. It can take the intimal flap partially and increase the dissection. This technique appears very easy on the monitor, but you have to be very gentle. What is your thought about this?
No, sir. Actually, in this technique, over the balloon inflation partially and then by deflating you advance, so that is automatic to the vessel wall. That is the main advantage of this technique. This is balloon assisted guide advancement.
Yes.
So very safe, automatic.
Yeah, prior to that, he has used 14-16 atmosphere of 3 millimeter NC balloon. So there will be some amount of intima floating over there. So that is why I tell them to be very careful, very gentle, and not to be rough with this. Otherwise, you can carry the intima distally and ultimately land up with a longer stent.
Definitely, you are absolutely correct, sir. We should be say, without dilation, if you can advance, but with dilation, you should be cautious when you're advancing the.
Yes, Dr. Refai, what are the dimensions of the stents which you have chosen?
We got this around 24, 25. So anyway, because I want to get 3 millimeter back into the left main, I've chosen a 3.5 by 28 millimeter Zion's stent to deploy in the circumflex first with a 2 millimeter or 3 millimeter hangout on the left main. And then I will just get a balloon ready for the crushing for the LAD. Sister, get a 3 balloon ready for LAD, okay? And do you need to show me the guidezilla entry point?
For the audience, I don't know how many are the audience. We are not able to communicate with the audience. This technique of taking the balloon in the LAD first, then taking the stent into the circumflex, these steps are very important so that you have a good decay crush. And choosing the size of the balloon for the crush is also important. Otherwise, your crush may not be adequate.
So I'm just going to pull the guidezilla back because now we have the stent in position. Because just test. So I'm just going to keep the guidezilla in left main just because I can see the pictures more clearly. Okay, I can pull back more. Okay, just pull back. Okay. Guidezilla back and get me a 3 balloon ready. Okay. So one of the things I can do is if I'm finding difficulty to push my 3 balloon through the LED wire, I may get the guidezilla out because now my stent is placed nicely. So I don't need the guidezilla if I have difficulty in passing my LED balloon on the side of the guidezilla.
I think it would be a very tight job to take a balloon on the side of the guidezilla.
Very difficult.
But this is a 6 guidezilla, so I have a feeling I may be able to get through because it's I've downgraded the guidezilla from 7 to 6 when we had the difficulty.
Yes. I would be very
But
vigilant about air balloons also.
I have a difficulty as the
Good.
yeah, I feel it now. Let's remove that. Just keep it on that. Let me just remove the guidezilla. Okay, and just line up for the stent. I may even push the stent down a little bit just to make to be on the safer side and then reposition the stent. Pulling back is more easier than.
Yeah.
Okay, one second. I'll just get the guidezilla back. That's LED wire. That's okay. Okay, that's running smoothly on the. Yeah, that's fine. Okay, circumflex wire. Yeah, thanks. Yeah, LED wire is also. That's okay. I'm just positioning the wires. Yeah, circumflex wire is fine. Okay, now I'm going to remove the guidezilla because my stent is. Okay. Okay, just be careful. Just you might as well just blow this balloon. Remove this balloon. This is the balloon. 1 second. We're going to fix everything. Introduce the. This is the balloon, yeah, LED balloon. So remove the LED balloon out. Okay, guys. This one. Stent, yeah. So we cannot completely remove it because the stent is connected. So I'm just going to keep it outside until I disconnect.
Did you have any problem advancing the LED balloon?
Yes, I did. On the side, we had a slight difficulty. So I'm going to keep it here and now give me the LED balloon system. So my guidezilla is kind of out, but I can't remove it out because the stent is connected to the thing. So but I pulled the guidezilla all the way back into the. And just give me N wire balloon. That's because I want to push keep the fix, just to fix this wire. Yeah. Yeah. So now my guidezilla is on the just outside, and my stent is in position. Now I'm pushing the balloon for crushing. Negative.
Yes.
Yeah. Okay. Negative on the balloon. Okay. Now we need to. Okay.
Hold the guidezilla like that.
Guidezilla, don't keep it like that because we cannot remove. Yeah. I just want the stent balloon now. The stent balloon, yeah. And we just need to push both guidezilla and stent balloon together. Or pull it back. Okay, fine. Now we are in. I know my guide is deplane, but just I'm going to take a picture to see where we are. I can pull back more. Okay, don't do anything. Wait. Hold on. Don't pull the guides and the stent back. Just trying to open the guide a little bit back. Yes, that's a good idea.
Yeah.
So
Now-
I'm just going to pull a test again.
Yes.
This is the stent.
Dr. Masuda, now that he is doing a DK crush, how do you choose the size of the LED balloon vis-a-vis the left main and the stent?
Yes, sir.
This LMT is too large.
That's the picture.
So bigger balloon is better. So for
And so I'm going to go up with the stent there. So this is 3.5.
millimeter balloon to LED.
Yeah. 1 second. Yeah. 6. Yeah. 8.
Dr. Refai, what is the size of your LED balloon?
I have a 3 just for the sake of it. I will pull back and crush it. This is a 3.5 stent, nicely opened up, as you can see.
Your left main looks to be about 4 millimeter. So will
So
a
I'm
3
planning
millimeter balloon be sufficient for that left main to crush the stent, circumflex stent?
Yeah, so what I'm planning to do is, because I have the balloon there, so like a sequential crushing. There are some talks about sequential crushing. You crush with the 3 and then go with the 4, crush again, and then take a stent. So that's what I'm thinking of doing, rather than taking a 4 straight away. And you can get the come down now.
Dr. Uday, sir.
Yes.
Yeah, no,
Sorry to interrupt you, sir. Now we can take the presentation, sir. You can ask the speakers to run the presentation, sir.
Okay. So, Dr. Refai, we'll come back to you. By the time you complete the case, we'll have some presentations.
Sure.
So,
That's fine.
start the transmission.
Yeah, just go up a little bit there. Just wait for it to slip down. Are you back on track? We are.
Yes.
Can you hear us?
Just summarize what you have done till now. We left.
Yeah. So the last time you saw was putting the circumflex stent, and we're just going to show you the thing since we did the circumflex stent. So we used the guidezilla, got the circumflex stent in position, and deployed the circumflex stent. And replay that, Andrew. Yeah. So that is the position of the circumflex stent. We finally decided to put around 3 millimeter into the left main. And this is around 14 atmosphere, 3.5 stent. And the next one is, I had the balloon on the LED. I pulled back the balloon and crushed. This is the first 3.3 millimeter crush. And the next one, we used a 4 millimeter balloon into the LED after removing the wire. So this is the next crush. Next one, Andrew. I don't know whether you can see us the angiographic screens.
They are very small. Can you enlarge the screen?
Yeah, we have enlarged it now. So after the 3 millimeter crush, so this is a 4 millimeter balloon. So I wanted to crush the stent again with a 4 millimeter balloon, as we discussed. So that is a 4 millimeter crush. And I used that 4 millimeter into the left main as well. And this is what we got after the first crushing. Next, and then I rewired it. So this is, I don't know that you can see a stent boost. So when I rewired it, I did a balloon on the LAD just to see where my crossing was. And you can see one of the things we can use apart from OCT is stent boost to see the crossing, where the position of the crossing. And by looking at the stent boost, you can nicely see the wire going into the proximal stent. Since it's a DK crush, I want to cross the struts of the proximal segment. So I confirmed that by keeping a balloon in the LAD and taking a stent boost, and confirming that the wire cross was actually a proximal cross. You can see now on a bigger screen. So you can see the wire is much more proximally, and you can see a lot of struts behind that. And then next one, and then I kept the same balloon in the LAD and then passed a 3.5 balloon into the circumflex to do the first kissing. Next one. Next one. That's fine. I just did the first kissing inflation, Andrew. So before I did the first kissing inflation, I also used a 2.5 to through the stent struts in the circumflex before I went for a kissing inflation of 3 in the circumflex and a 3.5 into the LAD. Next one, Andrew. So I used around 8 to 10 atmospheres in the LAD, and for the circumflex, I went up to 14. This is the first kiss, and next one, and then I decided to put the stent in the LAD. So this is the first stent. So we decided with the OCT images that we will go with the 2.5 millimeter stent from that mid LAD. So we put a 2.5 by 28 millimeter stent at around 10 atmospheres with normal pressure, and then I pulled back the 2.5 stent balloon and went very high pressure, and I also used that balloon to measure the length of the stent I need to put from the ostium of the left main stent. So you can see the inflation of that 2.5 millimeter stent balloon. And then I decided, when we decided, well, we'll go for a 4 by 33 millimeter to nicely overlap the LAD and also coming up to the ostium. So this is the 4 by 33 millimeter stent. Next one, Andrew. So I pull back the stent balloon because I don't want to go too high pressure in the LAD, and then pull back into the ostium and very high pressure. This is the first pot. So I went with the 4 again with a very high pressure of 20 atmosphere just proximal to the stent struts in the circumflex. And this is the picture we took after the first pot. And then I rewired it. This time the second rewiring, I got the rewire into the LAD and then pulled back, because for this second rewiring in a DK crush, either you want a distal crossover or a middle crossover. So I used that to go into the LAD and then pull back and just passed into the circumflex. And now we have 2 balloons for the second kiss ready for us. So I have a 3.5 into the circumflex, and LAD was a 4 millimeter balloon. Yeah. So this is LAD? LAD, yeah. So this is circumflex. So you can see circumflex is gently melting. So I'm going to go at 2-4 atmosphere first with circumflex. I'm assuming the balloon will slip forward with a just gentle inflation, 2-4. And then I'll pull the LAD balloon back and do a proper kissing inflation. Okay, and 6 down. Yeah, so now you can see now the circumflex balloon has nicely gone in. I save the fluoro and play. So once I did a 6 millimeter inflation, this is one of the techniques the Japanese operators are trying to push the stent struts out with the gentle inflation and push the balloon in, but I actually deflated and pushed it in, and you can see it's gone forward nicely. And now I'm going to pull the LAD balloon back. Yeah, you can see now LAD balloon and circumflex balloon are nicely positioned now. So we are ready for a for a second kissing. So LAD go up to 8, you go up to side branch go first. Yeah, 2, 4, 6, 8. 10. She goes to 8. Yeah, I don't want to go too high on the LAD, but circumflex we went. Yeah, so 3 balloon we go up to 14. Circumflex go up to 14. LAD stay at 8. 14. Okay. So I'm quite happy with the second kiss now. And down with the LAD balloon first, and then circ balloon. Yeah. Down first. Yeah. Right. Good. Yeah. So I'm just going to take the LED balloon and just take a picture, make sure everything is okay before I remove the whole balloons back in. And then the plan is to do a pot. Yeah, that's because of the balloon positioning. Play the previous picture, Andrew. Back one. I just want to make sure we got the ostium of the circumflex balloon. Yeah, we nicely got it. So we can remove both balloons and get the 4.5 balloon for the report for the left main, and then I'll do an OCT run. Circle will go fine. Yeah. 4.58 or 12 should be 4. Yeah. 8 should be okay as well. Yeah. So I just want to wire let's get the wire distally a little bit, both wires. Yeah. Once I do the port, we'll take a cine and then we'll do a OCT run with a short 4.5. It's a bulky balloon. Yeah. On the LED wire.
Okay, Dr. Refai, as we are operating, going for the final plot. Now you have used a 4 balloon and a 3 balloon, 4 in the LED and 3 in the circumflex, right? Or 3.5
Correct.
in the circumflex.
3.5. It was a 3.5, okay. But I will make sure that the 4 doesn't go too high. I went the 4 with the.
Tell me, I have one issue in the mind. You have already 4 plus 3.5 means effective diameter is 6 atmospheres in the left main.
Yeah.
Why do you need to go for a final pot now?
The circumflex stent was a 3.5. I don't want to use maybe I could have used a 3.5 for the left LED and kept the 3.5 for the circumflex. But I because I didn't have a 3.5 on the table, I used a 4, but I made sure that the 4 doesn't go beyond 6 or 8. So I didn't go too high pressure in the LED balloon, but the circumflex balloon with a 3.5 stent and a 3.5 balloon, we went up to 12.
Yeah, true.
12
so 4 plus 3.5 actually gives the effective diameter of approximately 6 or so in the left main.
Yeah, so but my only point is the left main was fully stented. I stented from the ostium of the left main stem. If I wouldn't have stented from the ostium of the left main stem, I'd be really worried about using these 2 bigger balloons. Now, since I stented from the ostium of the left main stem, I was not too worried about going with the higher balloons. So that's one of the advantages of using a stenting from the ostium of the left main. You can go gently more relaxed than if you lose a 5 millimeter in the left main, where if you go high pressure, it may dissect the left main back into. Andrew, ready for a cine? Stent boost and cine, Andrew?
Stent boost.
Andrew?
Stent
boost or cine? Just make sure you're in the pot. Yeah, yes, center. Yeah, if I didn't stent the ostium of the left main, if I had some 3 or 4 millimeter left in the left main without the stent, I would be very, very careful in using bigger balloons, particularly from both sides. So now you can see nicely my 4 balloon, it's 4.5 balloon is hanging, because the left main size we have on the OCT from the pull back was
stent boost again.
Stent boost. Sorry, I'm just going to do one more stent boost to show where we are. So you can see very nicely there. I don't know that you can see the stent boost on the images there.
Yes.
Yeah, we're going to show you in a bigger screen the stent boost to show our positioning of the balloon. So we are quite happy here. So I'm just going to go up to 16. Go up now. 18, and then, no, 1 second, let me just, yeah, fluoro. Yeah, go. 12, 14, 16. Yeah, so we had a luminal lumen area of left main on the dimension on the left main on the OCT was 4.75, and you can see from the 4 point, like average median of 4.4 and 5.2, so average is around 4.89. So I want to make sure that we get a good plot with a 4.5 at 20 atmospheres, please. So I wasn't very worried too much about using a bigger balloons. So this is at 20 atmospheres at a 4.5 balloon, which will give us to around 4.76, which I'm quite happy with the mean diameter we got on the OCT images. So down, I'm just going to give one more, pulling back a little bit more. Happy the pressures.
Pressures.
Yeah. Okay, I'm just pull the guide back, and one more stent boost, Andrew. Yeah. So this is the final plot I'm going to do, because I don't want any stent struts to be damaged by my guiding catheter. Yeah. So this is like a hangout. Now you can see my balloon is hanging out at the ostium. 1 second, we will show it on the bigger screen now. You can see this now. Okay, can you see the screen now? Yeah, so that's, I'm just like, my balloon is hanging out now. So we're going to go up to 22 atmospheres. Yeah,
Yes.
live.
In the meantime, Dr. Masuda, do you have access to flaring balloons at your center? Or ostial flaring balloon?
22.
The voice is small.
Yeah.
Do you have access to ostial flaring balloons?
So 4.522 is around 4.76. Yeah, so we're really 4.7. Just keep it 30 seconds. I'm ready for OCT.
Yeah, balloons for ostial flaring.
Down.
Ostial flaring.
Ostial frame.
Yes. Yes. Now you're now trying to inflate the balloon inside the ostium flare. Yeah. In US, there is a availability of balloon called as ostial flaring balloon, where the technique is such that the balloon, proximal part of the balloon is bigger than the distal part of the balloon, so the ostium gets well flared. These are used for all ostial lesions, including the renal arteries, which can get the stent can get flared beyond the ostium, especially in the aorta.
Is it different from a pot?
Yeah, slightly different, especially when you're doing an ostial stenting. So you can turn back and then do some flaring so that the struts get flared, opened up properly in the aorta.
Okay, sorry, I know. Okay, thank you very much.
Yeah, ready? Can you test again? Okay, ready for a picture? Yeah. So just before I do the OCT, I thought I'll just one picture. Okay, let's run the OCT, please, from the LAD.
Dr. Refai, to begin with, what was the renal function of this patient?
His renal function is absolutely normal with a GFR of 70. So that was not an issue. 0.6 is his creatinine. The only thing is his age, and which puts his CABG risk was, which increased the syntax score 2 to equivalent to the results of PCI when you have a syntax of 26 and a syntax score 2 with this age. And his LV is also, as I said, LV is also good.
Okay. No, I was asking I could have saved a dye injection, because as it is, we are going to use dye during OCT.
OCT, that's absolutely very valid point. Come closer. I just want to, because I want to see the coaxiality of the guiding as well, because I want to make sure the OCT runs smoothly. So I thought by taking an injection, I'll see the coaxiality of the guiding before I do a OCT. Because you know that otherwise the OCT will be sticking on the sides of the stent struts if the guiding is not coaxial. So we are in the LAD now. Wire. The OCT, just bring the wire. Yeah. Okay, so I don't think we don't need to go that far. Should we just see where we are? Because our stent starts somewhere there. Yeah. Shall I just just give a puff and see what you can see? Yeah. Puff. Clearance is not. That's okay, right? Yeah. So keep it straight. Keep the OCT catheter straight, and just say inject. Okay. Yeah. Go down a little bit more. Okay.
Go down.
Yeah. I'll push it down. Yeah. Now.
Go.
1 second. Yeah. Now. No, we are below the stent. I'll just give a puff one more time because I don't want to waste contrast. You happy? Okay, that's a good puff. I'm ready now. Yeah.
Clearance is not there.
Yeah. Okay.
You don't need to look.
Okay, we'll see what it shows and we'll decide. Just a more. So we're just reconstructing the OCT images. So that's the distal LAD stent was 2.5. Yeah. There's no edge dissections on the distal LAD stent. Edge just come inside. Yeah. There's a clearance was not great at that segment, so that's probably why it's showing under expansion. But I'm more interested in the left main. There is also some clearance disturbance there. There's some tissue protrusion there, and yeah, that's the just go the pork. So there's no malapposition. So as we know that we always follow the MLD max. So pre-stenting we follow morphology, length, and diameter dimensions, and for the post-stenting we wanted medial dissection, which was not there. And there is a slight malapposition, but I don't think it's 400 microns at that place. And so apposition and then expansion. So the expansion is also great. That segment is probably because of the clearance issue there. You can see the OCT, the longitudinal image is telling there is some stenosis, but it's actually not, because there is some clearance issue. Actually, the size is nicely bigger. So I just want to see a minimal stent area in the left main. Let's see what did we achieved at the left main. Yeah, just looking at the left main. Yeah, just to. Yeah, we are getting around 14.4 for the left main. So you can imagine how big this left main was. So that segment is 16.5, but overall the minimal stents cross-sectional area of stent in the left main is 14.4, and we also know from the images, from the data, particularly from the Excel, that anything above 10 is a very good result to reduce your MACE events in the next 3 to 4 years' time. Let me just remove this OCT. So I think at this level, I'm quite happy with I just want to see what is the bifurcation when we see the ostium circumflex stent there at the level. If it's not very clear. Yeah, you can see there's no stent struts at the level of bifurcation, as we can see from the OCT. Even though the picture is not clear, but clearly that at the level of the carina, there's not much stents crossing at the level there. Stent struts are pushed aside. Is anybody has any comments or any suggestions?
Oh, that's an excellent result there, especially the ostium of the circumflex.
Yeah.
Dr. Masuda, for your comments, please.
No comment. This is a very good result, I think.
Thank you. Thank you for that. Let's say just a few pictures on the angiographically. We'll take 1 or 2 pictures in different angles in the caudal view and a iliocranial angle. Yeah, we can just gently remove the wires. I don't want to lose push. Yeah, we'll remove the circ wire because you can go again and run a circumflex OCT. But considering his age and we discussed about the creatinine reason, that's normal. I don't want to go too much contrast. We have good result and we've shown the ostium of the circumflex on this. So I'm quite happy with that. So we're going to take last final 2-3 pictures and finish off unless anybody has any more suggestions. The plan is to remove the IABP in an hour or so because the ACT will be slightly high. I want to wait for the ACT to drop down to 150 and less, and then we'll remove the balloon pump because I don't think he needs long-term IABP or 24 hours at the even. So I may think of removing it tonight. Let's take 1 or 2 pictures on the cranial and the caudal view. Ready? Yes.
Oh, lovely result.
Angiographic. I mean, you can see the step down of the stent. You can see we put a 4 at the proximal LAD at a 2.5. So nicely you can see the tapering there because if you look at it, there is an aneurysmal segment at that LAD after the ostial lesion and we could only get a 4 there. So that's why I went for a 4.
So it's an excellent result, especially compared to what we started with in the evening, prior to with so much of calcium and lesions in the LAD, circumflex. And I think it's an excellent demonstration of various devices at various stages that you have used.
So the one of the thing was the OM where I had a slight plan if I can use a DCB on it, but now we can see a good flow in that OM. So I'm going to stop here rather than using a DCB into the OM. But the initial plan was to use maybe a DCB, but I have a slight feeling that a DCB with a 90-degree angle to get I need to use a long DCB, around 30 millimeter DCB to cover the whole of OM, and I may have difficulty crossing that. So I would stop that at this level. And I'm quite okay with the results we got, and I'm sure this will do a lot good for this gentleman at this age, and that will definitely make him much better in terms of his physical activity because he's very physically active guy. He's not somebody sitting at home. So that is the reason why we want to make sure that we get a fantastic results with this left main bifurcation. And I think the most important point I feel comfortable is one of the things is having an intra-aortic balloon pump, even though his LV function is normal. But having a left dominant system, and whenever we inflate, deflate, and we are doing kissing balloons, we always get worried about his pressure. But having an IABP on board, and in fact, we are actually doing 1:2 inflation of IABP. We didn't put 1:1 at all. So I think that is just to give us some boost for us to do the procedure in a more comfortable way rather than just panicking in between. Particularly, this is a long work to be done, DK crush. 2 ports, 2 crossing, 2 crossovers, and that's the reason why I used IABP on board. I think, of course, we can use Impella, but the cost of Impella is quite expensive at the present time, and that can be also used as a device as a backup device. And if I may leave the panel to have a discussion and tell us the final thoughts.
Yeah, Dr. Refai, excellent case demonstration of various devices. So may I request Dr. Masuda for his comments and summary and conclusion of the case, please?
Thank you very much for your tough case.
Thank you.
The final angiogram was excellent. So I really enjoyed and studied this case. Thank you so much.
Yes, thank you, Dr. Refai. I think
Thank
there
you,
are
sir.
no
Thank
comments
you,
there.
panel.
Yes, thank you for the case. Organizers, can we conclude?
Use to part, right?
Yes, sir, you may conclude. Sum up the whole session.
Okay. I would like to thank the organizers for organizing all his presentation. Dr. Masuda
Thank you.
for joining us all the way from Japan. Dr. Refai for having such an excellent case, a difficult case, and lot of energy required till the end of the day for all this, and for the presenters who have presented their cases. Thank you very much.
Thank you so
Thank
much.
you. Thanks for Abbott for organizing this and giving us the boost to be able to cases.
Thank you, sir. Thank you. Arigato
Good night to
gozaimasu.
all of you.
Arigato, arigato.
One is called capsule, and it's called E and fusion, and another capsule.